Hi, everyone. My name is Patrick Butler, and I'm the Vice President at the International Center for Journalists, Vice President for Content and Community. And we're happy to welcome you to another of our webinars that we're launching in a series of webinars as part of our global forum, Global Health Crisis Reporting Forum, which we've been running for almost a month now. We've done about 17 webinars. We have more than 2,500 journalists and health experts from around the world who have joined us on our Facebook forum. So if you found another way into this webinar, please do check out the Facebook forum and join it, because we're having lots of very vigorous conversations there about issues involved in covering this pandemic, both the health issues and the journalism issues, combating misinformation. Those are all the kinds of things that we're covering in the forum and in the webinars that we're doing. So I want to invite everyone to please submit questions for this chat. You can go to your chat room in the Zoom webinar and put your questions there. If you're watching us on Facebook, you can also submit questions in the Facebook forum, and my colleague will send them on to me in the Zoom chat. So please do submit questions. We've got a really great conversation ahead of us. We're going to be talking about South Africa and how its very different reactions to two pandemics, the HIV/AIDS pandemic and the COVID-19 pandemic, have really taught us some lessons about how journalists can be covering these global health crises. And our guest today is Mia Malan. She's a good friend and the founding editor-in-chief of Bhekisisa Centre for Health Journalism, which is a pioneering donor-funded media startup in South Africa. Bhekisisa has pioneered solutions journalism in the country, and its reporting has influenced several major social justice policies. Mia has 25 years of journalism, fundraising, and institution building experience in legacy media and digital native publications. She's worked in newsrooms and at media development organizations in Johannesburg, Nairobi, and Washington, D.C. She has helped grow Bhekisisa from a specialist desk at a legacy media outlet to an independent nonprofit for over the past 7 years. She is a former Knight International Journalism Fellow with our organization, ICFJ, and a Reuters Institute for the Study of Journalism Fellow at Oxford University. Mia has won 26 local and international awards for her radio, print, and television work. So let's get started. Thank you for joining us, Mia.
Thank you for inviting me.
Great. Well, first, why don't you give us an update on what's happening in South Africa in terms of how the virus is spreading there, how many cases and that type of thing, and then also what's going on in terms of the government's reaction.
Sure. So we had our first case on the 5th of March, and South Africa since then have acquired a few cases. We have about 2,500 cases now and just over 30 deaths. So it hasn't grown that quickly. And one of the reasons is because we went into a very strict lockdown at a very early stage of our outbreak. We started with a lockdown on the 26th of March, which is just more than 2 weeks after our first case. I think it was on the day of our first death. And it's a really strict lockdown. You're not allowed to go out for exercise. You can really only go out to buy groceries or to go to the doctor. You can't just take your dog for a walk. No alcohol sales are allowed, no cigarette sales. We've got the army and the police patrolling our streets, so it's not like you can try and cheat. It's not that easy. And we have essential workers who can go and work, of which the media is part. And we are now in the 3rd week of our lockdown. Initially, we only had a 3-week lockdown, but over the weekend, just before Easter, our president announced an extension of this lockdown for another 2 weeks. So we would have, in the end, a 5-week lockdown. We don't know if it will be extended further than that. But we've had quite good communication around COVID in our country, and we sort of understand the reasons. It's been very well communicated what will influence whether our lockdown gets extended or not. There was a national television broadcast by the government and the Ministerial Committee of Scientists on Friday, live on television and also on a Zoom call, and it was explained to us very clearly that if we have more than an average of 90 new infections or cases per day for this week, between 10th and 16th of April, we will have our lockdown extended. If we manage to have it, beneath that, then our lockdown won't get extended. So everyone is pretty much on the same page about that in the country. But of course, there are very dire consequences, like everywhere, of the lockdown, economic consequences. And in South Africa, particularly because we're such an unequal society, we have a lot of hunger, a lot of people who really just literally don't have food. And we haven't, while there is economic support from the government, it's limited, and that means we haven't seen, monthly checks, for instance, like we see that the US is going to start with, but they are a sort of like a limited form of grants and food packages for people. But we have seen incidents, for instance, over the weekend, grocery stores in Port Elizabeth in the eastern part of South Africa got looted because it was literally by people who didn't have food. So that is one of the reasons that our government is very seriously looking at, should they relax some of the rules for the lockdown to allow people to get some sort of income or not. But generally, I'm proud to say in my country, we've had a pretty much of an evidence-based response, and our government really responded very early in the outbreak.
So that is one, maybe a rare case of a government around the world that has responded quickly, forcefully, and based on science, as you said, evidence-based, obviously with a lot of consequences that are not so good, but the communication being a very positive thing. That contrasts quite in quite a big way to what you saw when you were covering HIV back in the late 90s and 2000s. Can you tell us a little bit about how that was different?
Yes, and it's a really actually nice story to tell because it has a good ending. But in the late 1990s, early 2000s, since HIV was really at the height of its growth in South Africa, and we, as you may recall, had a president, Thabo Mbeki, and a health Minister Mantu Shabalala Msimang, who doubted the link between HIV and AIDS. And more importantly, this resulted in them not giving people access to free treatment because they believed the treatment, antiretroviral treatment, they believed was poisonous. And we only got treatment at a very late stage in our HIV epidemic. And the consequences of that was, of course, that lots of people died unnecessarily in South Africa. There's a very widely quoted study now by Harvard University that calculated on the basis of modeling that more than 300,000 people died as a result of not having access to treatment at the right stage of our epidemic. And the consequences of that in South Africa was that with HIV, we had a very strong activism lobby. Like scientists really became activists, not just civil society. And the media's main source of information was really activists and not the government. Information was really not free flowing. And there were also lots of court cases. So we really only got treatment in South Africa because civil society took government to court, and the court then ordered them to make treatment available. And as a result, the activists and media were really enemies of the government. We were seen as traitors if we didn't support the government's views. And, we're a very young democracy and it's a very racialized country. So even sometimes allegations of racism if you didn't support the government. And essentially you were seen as an activist or a journalist if you supported the science, that you were essentially supporting Western science for an epidemic that disproportionately affected Africa, and that we should rather come up with a solution in Africa, which is of course a good idea. But if you then were against the government, you were perceived as not supporting the idea that Africa should come up with their own solution. And as a result, the media was very, very divided when it came to HIV. You know, whether a media organization supported the president or not was often a decision that was made on the basis of politics and not on science. And there were really like a divide in the media. Some people supported the president, some media organizations didn't, and it caused a lot of tension. And there's a lot of studies that have been done on the media's coverage of HIV during that time. And many of the studies show that as a result of the government's response, which was essentially a non-evidence-based response initially, the media stories really focused very much on the politics of HIV in the country. And if you were a health reporter during that time, you were essentially an AIDS reporter. That's almost all you did. And your stories looked more or less like this. You would quote the president if he said something that was unscientific, and then you would find an activist or a scientist to tell you why it's wrong, and that would be the story. And the studies that analyzed this coverage found a lot of the coverage wasn't very meaningful because it was sort of he said, she said stories, and that really dominated the coverage. Now, when it comes to COVID-19, our government's response has, of course, been the complete opposite of that. And as I've mentioned, we've had a very early response. Our lockdown started very early. We're in the process of dramatically expanding our testing. And we've seen results of the lockdown. We've seen a slowdown in the rate of infections. And we have seen a curve that has really started to flatten. Of course, this curve is going to change when we end the lockdown. But we've had time to prepare hospitals. We're in the process of setting up field hospitals. We don't have a lot of hospitalized cases yet, so we have time to prepare for that before that happens. And we've seen a pretty low death rate of just above 1% in South Africa of the confirmed cases. And we're expecting our epidemic to peak in September. The government has done projections that if we had a 3-week lockdown, our epidemic would peak in July. And if we have an extra 2 weeks of lockdown, it's likely to peak only in September. And they've achieved this by having a ministerial committee of 50 scientists that they really listen to. And there's a very nice one person to really sort of explain a concrete face of what it means to listen to government or not. And his name is Salim Abdul Karim. He's a very, quite a famous HIV scientist and an infectious diseases specialist. And during the time of HIV, Salim Abdul Karim didn't agree with the government and really tried to fight for access to treatment. And he was already then a very well-resourced, very well-acknowledged scientist. And he was in the open called a traitor, and he was called as someone who just wanted to show the government up, and the health minister really didn't listen to him and to any of the other scientists that tried to talk to them. And today, this very same Salim Abdul Karim is the chairperson of the ministerial COVID-19 committee. And he is the person who went live on national television on several stations on Sunday night in South Africa and explained in very, very simple language what is happening to COVID-19, why are we having a lockdown, what will determine what will epidemiologists use, what information to determine whether it's going to continue or not, and also explaining that we can't, even if you have a lockdown at an early stage, you can slow down the outbreak, but you cannot escape the peak that's eventually going to happen, and that you cannot escape, once you stop the lockdown, that there will be an increase in infections. And I think it's really empowered South Africans in the sense that you sort of know what you need to do to, you gave us a number, the 90 infections, and that we know that it sort of empowers you to stay more at home and not cheat if because essentially you know what the number is that they're going to use to make a decision. But with COVID-19, there's also been a very different type of communication, as I've mentioned, from our government, really the opposite of HIV. So in addition to Sunday night, when it comes to the media, there's a WhatsApp group that is only for the media, for a group of journalists, that you would get the new cases announced as they come in. The health minister is available for regular interviews, even the president. And the media has been called a partner of the government, which is a very strange thing for someone like me who reported on HIV, because it's really the opposite of it. And in addition to that, it's really something that you almost doubt because you're not used to it. And the government, I've never seen them being this open with any disease, even diseases where they've had evidence responses. For instance, if there's a measles outbreak or, in vaccinations, the information has never flowed as freely. It's not perfect information. You never know as a journalist, when are the new cases going to come in? Are they going to give you all the information? Sometimes they give you a breakdown of provinces, sometimes they don't. And at Bhekisisa, we have a partnership with another organization that is very good with data journalism, Media Hack, and we have a map that we break down these figures. And it's really challenging when the government doesn't release all the figures or, the entire breakdown every day, because it means you can't update certain parts of the map. But it's certainly not perceived as the government not wanting to give the information. It's rather a matter of, being a little bit disorganized, I would imagine.
To what do you attribute the difference? Is it simply the difference between two men, Bheki and Ramaphosa, or is it bigger than that?
I think it is one president taking science on board and another one not taking it on board. Thabo Mbeki had very strong doubts about the science of HIV. Also, our health minister, Zweli Mkhize, is a medical doctor himself. Then again, our health minister during the time of HIV was also a medical doctor, but it is someone who, Zweli Mkhize, lived through the time of HIV. I think he very clearly saw the consequences of actions. He was a provincial health minister at the time in a province that was very, very badly affected, KwaZulu-Natal, by the epidemic. And I think he also, interestingly, has a very strong relationship with Salim Abdul Karim, the chairperson of the ministerial committee. They studied together. So I think there were also personal connections who could inform him very well about what to do. But I think essentially there's a very strong appreciation of science. And I think something else that influenced our very quick response is the fact that the epidemic started in Europe and we could see what was happening. So we have evidence to use that countries that are now further along in their outbreaks didn't have to use. And I think the idea of COVID moving so quickly and the fact that we have a health system that is not any match, for instance, to Italy's, and look what happened in Italy, also scared us almost into action in addition to appreciating evidence.
Yeah, you talked earlier about the stories that were done during the HIV epidemic were not really helpful stories, I guess is one way to put it. And they were more about conflict and really just trying to figure out what the truth was when you have a president who doesn't accept what scientists say. What kinds of stories are you able to do now that you weren't doing then?
So, if you look at the stories that are being done now, first of all, we don't have to concentrate like many other journalists, and let's say in the US and in say the UK, journalists had to concentrate a lot on sort of correcting their country leaders like we had to do during the time of HIV. So we can sort of skip that phase in South Africa instantly because there's really no doubt about and move on, to stories about the actual outbreak. So we can concentrate on, because we agree with the evidence approach, we can concentrate on holding the government responsible to implement that approach. So it doesn't mean there's no critical coverage. We, for instance, the police and army are misbehaving. They abuse their power in the streets to get people back in their houses. We have put pressure on the government to speed up testing. Initially, there was a feeling in the country that testing didn't happen quick enough. We do stories about, what sort of tests to use. We're going to incorporate antibody tests, and they're quite controversial. We're going to incorporate in South Africa. So you can actually do meaningful stories that break down the science of those things, as opposed to fighting the government to implement those things. You can, after Sunday, for instance, at Bhekisisa, we took sound bites of Salim Abdul Karim's speech and took slides. He had a PowerPoint presentation and broke it down into sort of 1-minute sound bites that we're distributing in social media. That's a very helpful thing, not just for the government, but also for people to understand. It's something we would never have been able to do during HIV, you know, because there wouldn't have been any presentations like that. So in the end, we can do meaningful stories. For instance, you would see stories about comparing our results and our approach to that of other countries. You can see stories about, you know, features about following a tracer who traces the contacts of someone who has been infected, and explaining the process around that and how it works, why it's important to trace those people and how they're being traced and how it can have an impact on you yourself. So in the end, we see a lot of stories that can empower people with information, as opposed to ones that fight a country leader.
And do you have any advice, given what you learned during the very different atmosphere in the 90s and 2000s, for journalists now who are working in countries where leaders are more like Mbeki was, where they don't necessarily accept what the scientists are telling them? And those journalists may be doing the same kind of reporting you were doing back then, of just sort of, you know, more conflict-based, contradicting what the government is saying. Do you think they should try to do more of the you know, sort of useful for the reader reporting that you're doing now? Is that something that that may be a lesson that we can learn from what happened in South Africa back then?
So it's such a difficult thing to answer, Patrick, because you can't tell the media not to correct a president, essentially, right? If President Trump says there's an unproven treatment that works, surely you should correct that. But I think a valuable lesson from South Africa is, during the time of HIV, we got a very strong activism lobby, which we don't have activists for COVID-19 now. We don't have science activists, you know, we've got people who advocate for human rights and that sort of thing. So a valuable lesson was that activists can be a very, very strong sort of support form for the media to get access to human faces for stories and to get access to information. And I think something that activists learned during HIV in South Africa was that every time that the president made a statement that was inaccurate, they used it as an opportunity not just to counter him, but to say something more. So if he, for instance, said, you know, antiretrovirals don't work, they were very organized. They didn't just respond. Their message wasn't just, no, it does work. Their message would be, it's an opportunity to explain how they work, why we need them, and where we can get them from. And I think even though many of the stories weren't that meaningful during the time of HIV, trying to sort of think a bit ahead of also where can you get them from, a sort of a solutions-based approach, did help some stories to give information of sort of like, you know, why do we need treatment, how does it work, and how can the government find it. But I do think that something we didn't do during the time of HIV that we missed because we focused so much on the politics of the epidemic was that we very rarely saw stories in South Africa that looked at lessons from other countries. And I think that would have been very helpful. It could even have informed the president, or, you know, been a sort of a form of activism against him to see what approaches work in other countries. And that's perhaps something that I think journalists in countries where there's a lot of controversy could focus on, because it could be a direct opposition, you know, evidence from other countries and strategies that they have used, and seeing how it can be applied in that country. It's a tool that you present, and if the president or you know, government leaders don't use it, there could be some showing up of sort of like, there is a tool and why aren't you using it? So I think lessons from other countries and solutions-based journalism.
Well, it sounds like we could all learn some lessons from the way South Africa is handling it, actually. So that's one lessons learned that we should be doing. Now, another question. Bhekisisa recently reported that 4 in 10 people with HIV in South Africa are not getting treatment. And so I wanted to ask you what, in terms of the health issues that South Africa and many other countries in Africa and other parts of the world had already before COVID-19 came, are those going to exacerbate the problem in both in terms of people who have HIV and are not getting treatment? Tuberculosis is another big problem. Are those factors going to make it worse in countries where those are rampant?
So the short answer is we don't know. And the reason we don't know is because the countries in Europe and China and the US where the outbreak and the epidemic is ahead of South Africa don't have high HIV infection and TB rates. So we don't have data to use when it comes to this. But what we can do is we can make educated guesses and we can take clues from other viruses. For instance, in South Africa, we have data that shows us if someone who has HIV, who is not on treatment, so who doesn't use antiretroviral drugs, if they get measles or if they get influenza, their response is much worse to that virus than what it would be for someone with HIV who is on treatment or someone who is HIV negative. So we can make an educated guess to think that if someone has HIV and they're not in treatment, it is potentially possible that they will respond to it in a way that that an older person responds to it because the immune system would be very, very suppressed, or that a person like with diabetes would respond to it. We know that diabetes or asthma has an influence on whether someone who is infected gets serious COVID disease or not. Now, one aspect of this is that Africa has a young population, which should technically count in its favor, because we know with COVID-19 that young people are less likely to die and less likely to respond to the virus in a bad way. But with HIV, for instance, it affects young people. In South Africa, the young women in South Africa is the group among which HIV grows in the new infections grows the fastest. So potentially it could take away the benefit of age in Africa because of the high HIV infection rates, particularly in South Africa. But I have to point out that we really just don't know because we haven't seen. There's been some comments about people who use antiretrovirals because it fights a virus, that it might count in their favor, but it really is not anything proven, and we have no data for that. What we need is for someone to do research on that. At the moment, we just don't know.
Another difference between many parts of Africa, and again, many other parts of the world too, and the northern countries where we've seen the biggest outbreaks, is that people have said that social distancing is going to be almost impossible in countries where people are crammed into very poor and very crowded neighborhoods, the townships in South Africa, for example. But yet, it sounds like you're having success in keeping people at home. Do you think that's a valid comparison? In other words, that African countries are going to have a much harder time with social distancing, or are you seeing in South Africa that it's actually achievable?
No, it actually isn't doable in terms of people who live in our crowded conditions. So in South Africa, you know, South Africa is one of the most unequal societies in the world. So to just give you a figure, in the country, 86% of South Africans don't have any form of health insurance. They have to use very dilapidated public health facilities. And so only 14% has insurance, and roughly only 14% in the country earns enough to be, for instance, be able to pay taxes. So the result of that is that the largest part of South Africa is poor. And that means that a very large part of this country doesn't have access to any running water. They live in informal settlements where there are no running taps, and where people live in shacks that they just make from whatever they can find, and they live in overcrowded conditions. And the two most effective ways to prevent to prevent yourself from getting infected is to wash your hands and to stay 1 to 2 meters apart from someone. That is simply not possible in a large part of this country. So we can do it in a formal way where we prevent people from going to shops and we don't have, large gatherings. But when people go home or when they live in a township, they can't do that. So what the government has done, and the consequences of that, is one of it is that we last week announced that that is recommended that everyone should wear a cloth mask. I know a regulation in the US as well, but in South Africa it was really done so that people in communities where you can't do social distancing has some form of protection. We know that cloth masks don't protect you from getting the virus. You know that it only prevents you if you're infected from spreading the virus, but our government feels there will be a net effect. So everyone now in South Africa who goes to a shop, it's recommended that you wear a cloth mask. But one of the really serious cost consequences of people not being able to do social distancing is that if someone is infected, where are you going to tell them to go to? They have to go into quarantine and they can't do it at home. So there's budget implications for this, because our government has had to find places to send people to allow them to self-isolate. That means many schools at the moment that are closed have been turned into quarantine facilities. Lots of public buildings have been turned into not necessarily hospitals where people can treat it, but places where people can self-isolate. And there's also social aspects to look at. So what happens if you split up a family, or if there's no care for children? Who are you going to get to look after those children if they're not infected? So in countries like mine, COVID-19 has really highlighted the inequality, and the lockdown impact is different on different people. If you're a middle-class person, I'm very fortunate. I come from the middle class. I can do that at home. At best, I work from home, or I'm a little bored. But people who are poor in this country literally die of hunger. And, I went to the shops. I go about once a week. I've never seen so many people beg for food. And it's not the normal people who beg. It is people who, have security jobs, who have uniforms, who don't have money. And I think from that perspective, there's also been a lot of highlighting because of COVID, the sort of unethical practices of the private healthcare sector and pharmaceutical sector. For tests in the private sector at the beginning of the epidemic, they cost double of what they're supposed to cost. So there's been a lot of pressure on private labs to bring down their prices because the government pointed out what they really cost. And I think we've also learned that there's a real need for the private and public sector to work together in South Africa, something that they're not used to doing. They very rarely do that. But we've learned that there is no way that we're going to get through this outbreak unless they work together. So we've had things like that we've never seen before. The private sector will sometimes work with the government, but they're not going to offer a service for free, for instance. We've seen offers of, in KwaZulu-Natal, one of our provinces, of free beds that's offered to the government in a private hospital for when we have many hospital cases, really at no cost, allowing the government to bring in their own staff to work in a private hospital and to share machines and ventilators. We've never seen that before in South Africa.
Yeah. I'm going to turn to some questions from our audience in just a moment. I'm going to ask you one more question that I know a lot of people in the Northern Hemisphere might be wondering, which is, of course, we're coming out of our winter and heading into summer, and there's some speculation that, like the flu, it may subside in our summer, but you're on the opposite schedule. So you're coming out of your summer and heading into winter. What are people in South Africa thinking about what the likelihood is that the weather will change the way the pandemic is spreading in your country or in the global South in general?
So I'm so glad you asked that question, because it's something we struggled with reporting on initially, and there really is no conclusive research that summer would slow down the COVID outbreak. So what happened to us in reporting is quite interesting. So our very first story on COVID was on the weather, because we interviewed the head of our COVID team, and her comment was, don't worry, it is summer in South Africa, COVID is not going to spread. And we then got taken on social media about this because scientists starting to told us that no, that this is not the case. And we started to look at research and then learned that it's really inconclusive research, that there's no clear evidence to show that the virus spreads slower in a country where it's summer, and not that the studies really is not, they're not conclusive. There are some small studies that have found that there might be a slightly slower spread, but it's not conclusive. So we had to adjust our story and work in the research and change our message. And that's an interesting thing because the person who gave us that interview was a scientist herself, and then also had to be taken on and told that no, it's not the case.
Mm. All right, well, let's take some questions from our audience here on Zoom and on Facebook. From Elizabeth Gold is asking, Mia, are you concerned about the impact of COVID on HIV prevention and treatment efforts in South Africa, and what needs to be done to avoid progressing?
So that's a great question, because one of the ways that we want to expand our testing in South Africa is to use a machine that we use to do TB testing. It's called a Gene Expert machine, and it uses the same technology, PCR technology, of the traditional lab test, but it produces results in a much quicker way, in 45 minutes compared to 24 hours. And we have many of those machines in South Africa because we use them for TB testing to see if someone has multi-drug resistant TB or not. And now we're going to use all of these machines to test for COVID. And there is a concern, a valid concern, that we're not going to be able to do the TB testing. So yes, in terms of TB prevention, we are concerned about that. And in terms of the traditional lab test, the PCR technology that the world uses for COVID, to detect the new coronavirus, is the same test that we use in South Africa to measure how much virus there is in someone with HIV's blood. It's called the viral load test. And all our labs that are used for HIV, viral load testing are now going to be used for to test for the new coronavirus. So there would definitely be an impact on our capacity to address HIV and TB. I don't think we'll be able to do the same amount of testing while we're doing COVID.
Okay. And then a question that I'm not sure, it's about vaccinations, from Dr. Osborne Nelson, who's writing from the West Indies. And he says that there are some conflicting reports about BCG vaccination and coronavirus diseases. So some scientists are suggesting that countries with low vaccination rates are being badly hit by this disease, such as Italy and Spain. I don't know if you've seen any stories on that and can speak to whether that's a factor that we should be alerting people to.
Yes, that was actually, interestingly, a factor that was addressed on Sunday night's presentation for the government. And the short for that of South Africa's view on that is that we have no evidence for that. So the countries, Europe is ahead of us with the epidemic. We are behind. We have pretty much, universal in South Africa BCG vaccination, because TB is such an issue, but that vaccination does not prevent you from getting TB. It just prevents you from getting serious TB disease, from falling very ill with TB. And the issue with the research at the moment is that in countries where they might have seen some sort of results, there's not universal coverage of the BCG vaccine because those countries don't struggle with TB. So essentially, where we're at, according to our chief scientist, is that we need someone to do research on it, because we can't say whether that has an impact in Africa yet, because the outbreak hasn't spread far enough for us to know if there has been an impact. We very much would like for it to have an impact. We would love it if it works, but we don't know.
Okay, there's so many questions we still have to find out about this. Another question here is from Priyanka Vora, who's asking what the cost of testing is in South Africa at private labs. And I think another question actually from someone else, really just about testing in general. You said earlier that South Africa is doing pretty widespread testing, is that right?
Yes, so it's a good question, the one of the private sector, because what did it cost at the beginning of the epidemic and what does it cost now.
Mm.
So at the beginning of the outbreak, it was anything in South African money. I'm trying to convert that to dollars. You know, in South African money, it was anything between sort of 1,500 rands and 2,000 rands, which is roughly sort of $12. I would, if I do a quick calculation, it has gone down to half of that price. Essentially, it's around about 800 rands now. That's the real cost. But you can go to government and get a free test. You're likely to perhaps wait a bit longer, you know, in a queue to get the test.
Mm-hmm.
But you can also request at a private doctor for the doctor to send it to a government lab if they did the swab at the facility from you. So what has happened to testing for expansion is initially we really only had people go to mostly private labs because it was at the imported stage of the outbreak. It was mainly people coming in from Europe or from a high-risk country who brought the virus, and now we're at the stage where we have local spread. So for the local spread stage, we now have 10,000. There's not agreement on the numbers. It's either 10,000 or 20,000. There's different numbers that are going around. But field workers who literally go to hotspots and knock on people's doors, screen them, ask them a list of questions, and if they fit criteria for testing, either take them by the hand to a clinic to get tested or tell them where to go. So that only started to kick in last week, at the beginning of last week, if I remember correctly. And we have screened, I forgot the numbers now, but I think it's close to you know, close to 400,000 people who have been screened. Wow. Testing is far less than that. Our calculations are that we need to test 1% of the population, 600,000 people, within the next 3 or 4 weeks, so that we have a good sample to tell us where the virus is traveling.
Okay. A question from Sherry Riccardi that's, I think, very interesting. You talked a little bit earlier about the WhatsApp groups that the government is using to communicate better with journalists. Can you talk a little bit more about how that was set up and how it's working? And I think journalists in the world would love to have something like that in their countries.
So, you know, it was really simple. It was simply the spokesperson, you know, of the minister who set up a group and added the journalists she knew, health journalists, and then, you know, added other journalists she didn't know before COVID that she wouldn't usually work with. And since then, there have been several groups, like WhatsApp sort of goes, you know, so there is a more general group as well, but that is pretty much the one on which the figures get sent out. There's also a group, because we have a lot of virtual press conferences now, and even before the virtual press conferences, if they were held in Johannesburg, someone couldn't fly into them. So there's a WhatsApp group where you can send your questions to for a minister at a press conference. So how it normally works here is if the president makes an announcement, say for instance, when he announced the state of disaster and then he gazetted it in the government gazette, and then there would be a set of rules that needs to be announced. That would be followed by a range of ministers having a press conference, because they would each have something to say, you know, whether it's the transport minister who now has rules for transport, or, you know, the Minister of Education who would close down schools. And then you would send in questions to that WhatsApp group that will then get asked to them. Like with anything else, I don't think all the questions always get put to the ministers because there's a time limit, but a pretty fair amount of them do. I've sent in questions and they were answered. And all the press conferences are live streamed, are broadcast on national television, so you can then see the minister respond to your question.
You know, we talk a lot about how our world is going to be different once we finally say get a vaccine, and I wonder if that's the kind of thing that could change permanently in South Africa. Is the government's method, well, as long as future governments are as responsible as this one, the government's methods of communicating with journalists, that's really exemplary.
It's really a lot quicker, I can tell you.
Yeah.
Yeah. I mean, one thing I must point out, they're often late, right? It often doesn't start.
Okay.
Late.
Better late than never, I guess. I wanted to ask you too about Africa. You know, I've seen some reporting that governments in the north are really competing to be the ones that develop the vaccine, develop treatments, so that, you know, they can protect their populations, obviously. Is there concern in Africa that you and other parts of the global south are going to be left behind by that? In other words, the vaccines are going to be used by the United States and Europe, and and Africans just won't get them, or they'll be too expensive?
Well, I think there's always that concern with anything in the health world when it comes to the global south. And it's not just that there's a concern that then global north would, take it for themselves first. It's the price, because we can generally not afford to pay the same price as the global north for the same drug. So when it comes to antiretroviral drugs, we get them significantly cheaper than they would cost, for instance, in America. Now, I think as a result of that, several mechanisms has been set up that can really help us. So, the Global Fund for HIV, TB, and Malaria has a mechanism, the UN has a mechanism whereby they buy the drugs and then and negotiate a price with pharmaceuticals, and because they buy in bulk and then distribute it in Africa or countries that need it. Something that has developed for vaccines in Africa that is a very helpful group is Gavi, which is an organization that provides vaccines to countries for free and then has an agreement with them to eventually for them to pay a little bit of it. South Africa is different. We don't qualify for Gavi. We pay, for instance, for all our ARVs ourselves, our antiretroviral drugs, and we pay for all our vaccines ourselves. And because of Africa that has been abused, we learned from HIV. So we've got very strong and strict rules in place in South Africa, specifically when it comes to trials, when you can do it, ethics, when you can't. It's not that easy to abuse it any longer. It happened during the time of HIV. So I think we sort of a little bit covered for South Africa there, but there really always is a concern. And I think in all aspects, the global north always has some loopholes where the global south can be abused, and it sadly still happens.
No, we heard that with the two French doctors who sort of assured the French population that the tests would be done in Africa. Now, they were not speaking truthfully, but that caused quite a ruckus, obviously, for good reason. We have a question here from Brazil, from Antonio Juniao, who is saying that we have a bigger problem than South Africa regarding sub-notifications for COVID-19 because we do not have enough tests. For an idea, he said, the numbers on the pandemic around the world, South Africa has 1,500 tests per 1 million inhabitants, and Brazil has only 300. So he wants to know a little bit about how South Africans took action to get the South African government to improve and make sure that there was more testing and notification. So I guess it's a little bit of what you were talking earlier about activists and journalists sort of demanding better actions from their governments. How did you do it?
So initially, like everyone, we struggled, and we still struggle. The entire world struggles to get enough tests. So initially, we had extremely strict testing criteria. It was very hard to qualify for a test. You had to have certain symptoms, plus you needed to have traveled somewhere. And without that, they wouldn't have tested you. And now that testing criteria has been relaxed because so it's easier to qualify for a test, and it's also easier there are more testing sites to get to have access to one. So what did we do? Well, I think there was pressure on the government, not just from the media, I think very much from the ministerial committee in terms of advice, that we would never be able to test enough people in South Africa if we only use the traditional PCR lab test. It's impossible for us to move quickly enough. When I mentioned we need to do 600,000 tests, we can't do 6 months to do. It can't take a long time to do it, because then there would have been many more infections during that time. Wouldn't know where, it wouldn't really tell us in real time where the virus is, so we have to do it quickly. So the result of that has been that we're using the TB test. We don't have the reagents yet, as far as I know. So we've got the machines to do the test and to go to sort of to take out mobile testing vans, but we're waiting for reagents. I'm hoping maybe in the past 2 days or so it's arrived. The more controversial part of that is that we are thinking of using antibody tests, of which there's sometimes is a little bit of doubt about the accuracy. Now, the interesting thing about antibody tests in South Africa is the support for them come from the HIV world, because we are so used to HIV tests that evolved from, there's there's PCR tests, but there's also antibody tests. And initially we used a lab-based test for HIV testing, and then it evolved to rapid tests, which is what we are looking at. So, you know, if you use a rapid test, it's quick. It's within 15 to 20 minutes, you'll have the coronavirus result and you'll be able to act. So interestingly, we have a very nice plan around that. We're going to bring them in. We're busy licensing. I think 12 tests have been approved, and we're going to give all people, when we get them, both a PCR test and an antibody test, so that we can do our own little small trial to see how accurate they are. And the plan at the moment is that if we see they are, you know, accurate equally to a PCR test, we are likely to drop the PCR tests entirely in South Africa and just use antibody tests. That is, of course, only if we have good results. If we don't, the government will look at other tests. What did we do to get them there? We did reporting. For instance, there is a lot of resistance from certain sectors to antibody tests in South Africa. At Bhekisisa, we do stories that explain the science of it and explains the government's plans, so that we want to put pressure on the government to have one voice, so that everyone talks about the same testing plan. And if there is one component, you know, in the government structure that doesn't support it, that we almost force them through coverage to say the same thing.
Yeah, and of course, Brazil is one of those countries where the leader of the country is sort of a denier. So I'm sure that's part of the reason as well why Antonio is writing and finding it difficult to get enough testing. We're getting a number of questions around the lockdown and its impact. You talked earlier about its impact on very poor people who are not working and who are you know, very, very needing food, just basics, very, very badly. Another question from Tammy was about universities in South Africa. She is South African, expecting students to continue with academic work throughout this period, despite inequalities in the countries and a very, very large digital divide. And then a question that I had was sort of about the impact on media organizations. We're seeing that many media organizations are really struggling as advertising drops, as other ways of raising money to support media. Are you seeing that in South Africa as well?
Okay, so I'll start with the education issue. I think that's a very valid point. Everyone in you can't assume everyone in South Africa has access to the internet at home. It doesn't work that way. So what you've seen with schools, for instance, is with private schools, education can, you know, continue to a large extent because classes have Zoom calls and teachers teach them online. But with government no-fee schools, that is not possible because children really come from environments where there is no internet at home. And I think when you get to university in South Africa, just because people go to the same university doesn't mean that they come from homes or from environments with the same amount of resources. There's a very large government scheme that allow poorer students to go to university for free. So they always at a disadvantage because they might have free university education, but it doesn't come with the other resources. Mm-hmm. And I think that is a very difficult thing to address in South Africa because so many university students only have access to, you know, Google searches when they're at their actual universities. And I'm not sure what the answer is. I can just say that I acknowledge that inequality, and I think I don't know what the answer is because you can't go and give people a venue. They're not supposed to go outside of home. But in terms of the media, yes, there has certainly been an impact. One of our legacy newspapers, the Malan, which is a relatively small independent media group, so they don't have a lot of resources. It's not like they can rely on another publication that still makes money. It's only that publication. And they have had an open call, their editor 2 weeks ago through an editorial that they've never been that open before, saying that they don't have money for salaries for the next month as a direct result of COVID because 70% of their income come from events that they can no longer have and from advertising, and there's not a lot of need for advertising at the moment. On the other hand, there's also been a lot of innovation. So the Daily Maverick, which is another group in media group in South Africa, actually used the opportunity to do sponsored webinars. So they got a large banking group to sponsor a range of COVID webinars, and to, I think they're at their third one now, and there are quite a few more coming up. So they found a way to generate income through it. I think that the requirement is just that you have to change so quickly. You know, we never had webinars in South Africa. It's not really part of our culture. And all of a sudden, you needed to understand the technology and do it, and have people who are willing to join a webinar. It seems to have been successful. At Bhekisisa, we're going to do our first webinar on Monday. We've never done one before, and we also got a sponsor pretty quickly. So I think there are opportunities as well.
But it also does raise the digital divide question again. If some of your audience doesn't have access to you know, a computer to watch, although I guess you can watch on phones as well. So. But
yes, and the interesting thing that you talk about the digital divide is the Daily Maverick is an online-only publication. The Malan has a print component. So if you still have a print component, I think the impact is bigger, because you also still need to print and distribute a newspaper that might not be bought that readily now.
Right. Another question regarding sanitizers and face masks. Much of the world is seeing great shortages of these. And yet making it mandatory in some cases that people have to wear them. What kind of issues are you seeing in terms of supplies, and whether the government is doing anything to help its citizens? And is there enforcement of that in the streets if someone is not wearing a mask, for example?
No, in South Africa, it's a recommendation. It's not a legal requirement. And the reason it's cloth masks and not medical masks is twofold. I mean, you know, the ones that you can buy from chemists, the one is that health workers may need them, so we don't want to use those for general people. But the other reason is because you can't force people to wear things that they can't afford. And a large part of this country can't afford it. So the government decided on cloth masks because they argue anyone can make them. I don't know if that is 100% true, but they argue that you can use what you have at home and try and make them. In terms of sanitizers, you know, an interesting thing in South Africa is that part of our lockdown is no alcohol sales are allowed, no alcohol production. So alcohol companies have started to produce sanitizers because they have access to a lot of alcohol, and it's alcohol sanitizers that you want to use in the epidemic, and they've provided it for free. They actually don't charge for it. So one consequence of the government's, you know, response that is well embraced is that it's brought on in a lot of free will from sectors that would previously not have given stuff for free. So the government isn't necessarily widely distributing sanitizers, but there's a lot of people that they've roped in who do it.
Okay, well, and I imagine the ban on alcohol sales was probably one of the more controversial parts of the government response, I would guess.
Very controversial, and there's a court case coming up. Our alcohol group is taking them to court, yeah.
Okay. And then I'll just finish with one last question that kind of helps us wrap things up in terms of advice you have from your long career in covering health issues, from HIV and up to COVID-19 and much in between. What kind of advice do you have for journalists around the world in terms of the kind of stories maybe that we're not seeing enough of?
So, you know, the interesting thing with something like COVID is that it's not just science or health reporters reporting on it, it's everyone. And I think particularly investigative journalists have often a little bit of a different way of looking at stories. So in South Africa, that would mean that you really investigate corruption a lot. There's a lot of, you know, corruption to investigate. So the interesting thing that I have seen, for instance, from investigative journalists in South Africa is that they would look for a corruption story where there isn't one because they're so used to looking for that. So in one case, for instance, here, there was a journalist that I really like, but that did a story about projections, you know, got a hold of a document that no one had seen and what would COVID look like. And I didn't think it was very helpful, but I think the journalist was really looking for a big break story. So my advice would be, in something like COVID, don't try and have something first necessarily. There are not that many big breaks here. Rather make it meaningful. Because in a large-scale epidemic like this, your role is really not just to to get information out first. Your role is to package it in a way that people can use it. And you know that with science, most people are not comfortable with science and they find it boring. So our role as journalists here is to make it interesting and to break it down so that someone can use it. Because in this case, that science can save lives. It's not just a matter of giving people just a bit of information. It can be the difference between you getting infected or not. So spend a bit of time on making stories meaningful and ask a scientist. That's the thing that I've done most of my journalism career. If I'm not sure, don't just assume a scientific fact is correct. Ask a scientist. I think scientists who are normally impatient, not that tolerant of the media, are pretty much changing during this epidemic, because it affects everyone. There's nothing that protects you from it other than doing what the science says. Having money or your gender or where you come from plays absolutely no role in whether you're going to contract the virus or not. The correct information here will save lives. The last lesson about that is, I think what we learned from HIV is when you have messaging about something, a scary message is not helpful. During the time of HIV, saying HIV kills was never helpful because it actually scares people so much that they don't go for testing. They start to get stigmatized. It works much better to just have a neutral, fact-based message rather than trying to say something kills.
Oh, that's very interesting. Now, I said that was going to be the last question, but we had one come in that I think is a very, very good and very topical question because it deals with something that just happened. It's from, okay, I'm going to try this. Bhekisisa is the journalist who sent this, and he says that Donald Trump's cutting funding for the WHO as he's announced. What is the impact of that on Africans?
Well, a large part of the WHO's funding goes to the global south, or their efforts, the money is used to address the global south. So there will certainly be less money to address the health problems, not just COVID, any health problem in Africa. And it comes at a very, very bad time. It's, in my opinion, a very unwise and selfish decision.
Okay. Well, thank you so much, Mia Malan, for joining us for this very, very interesting webinar. I think we learned a lot, both about, sort of the differences between your government's responses to these two pandemics, but also what lessons we as journalists can learn from them. So thank you for that. I would also like to remind everyone that we'll be posting a video of this chat on Facebook. So if you came in the middle of it, you'll be able to see the whole thing. Or if you have colleagues who would like to watch it, you can share it with them. We'll also post a summary of the key points of this talk, and we'll also further resources that may be able to help you. This is an on-the-record talk, so feel free to use any quotes from Mia or myself. Don't forget to visit our ijnet.org website, where we have lots and lots of resources in many different languages, 7 right now, and we're about to add our 8th language, French, which should be very useful for many African journalists. We did announce just yesterday that we're creating new forums like this one in Spanish, French, and Portuguese, and we hope that we'll be able to add more languages in the future. I'd also like to remind you about other webinars that we have coming up. We have 4 webinars next week. 2 of them will be helping journalists fight the infodemic, as we've heard it called, the spread of mis and disinformation around the pandemic. One will be in English and one in Spanish. For the English one, we're teaming up with the Digital Forensic Research Lab at the Atlantic Council to help, which is really focusing on helping journalists fight disinformation. And Andy Carvin from DFR Labs will be joining us for that one. We'll also have a training on how to use data in your COVID-19 reporting with Italian data journalist Davide Montino. And we'll delve into the issue of how journalists can stay safe while reporting on the pandemic with Kate McMahon of the Dart Center's Asia Pacific office, and Abir Sadi, a veteran Egyptian journalist and trainer for ICFJ and other organizations, and she's an advisor to the Ethical Journalism Network. So once again, thank you, Mia, for being with us. Thank you to all of you for your questions. I wish I could have gotten to all of them. We had lots of really good questions, but we encourage you to join us for more webinars next week, and stay safe, everyone. Thanks.